Good evening, everyone. Welcome to the October meeting of the Academy of Integrative Health and Medicine's Cleveland chapter. I'm Peter Geller, co-leader of the chapter, along with Dr. Amy Cipolla, who I think is going to be joining us shortly. And also here tonight is Serena Lee, who is a fourth-year medical student at the Case Western Reserve University School of Medicine, and she is one of our chapter's 3 leadership associates, student associates. And Serena is the one who put tonight's event together. So I am in short order going to hand everything over to her to make the main introduction. I just want to say that tonight we are honored to be hosting Dr. Katie Hu, who is the Associate Director of the UCLA Center for East-West Medicine. And Dr. Hu is going to be speaking something about the origins of the program, the workings of the program, and I hope she's going to say something about the secret of the longevity of the program, because it is one of the oldest that's been in continuous existence around. And so with that, I'm going to hand everything over to you, Serena.
Hi, everyone. Thank you for being here. Yeah, I'm also really excited for this talk, and thank you to Dr. Katie Hu for coming and speaking to us. So I'll just quickly introduce her. Dr. Katie Hu is a double board certified family medicine and integrative medicine physician who currently serves as the associate director, as we said, for the UCLA Center for East-West Medicine in Santa Monica, California. She's also the program director for the UCLA East-West Integrative Medicine Fellowship Program, the co-director for the East-West Pediatrics Program, and an assistant clinical professor at the David Geffen School of Medicine. And in her whole person approach to health and healing, Dr. Hu's specialties include women's health, adolescent health, and traditional Chinese medicine. So we're really excited to have her speak, and I'll hand over the mic to her.
Thank you, Serena. I want to thank everyone for having me here. I don't actually get to give lectures like this very often. Usually it's like, oh, come talk to us about acupuncture, come talk to us about fibromyalgia or, certain conditions. So opportunities like this actually invite reflection. So I took some time to review and summarizing our work. Actually made me really proud of where I am and how the center kind of got here. So thank you. Okay, so let me proceed here. Let's see. All right, so this slide is just a little bit about our background. So the Center for East-West Medicine started and founded in 1993 by Dr. Kaki Hui. And it's actually one of the first academic integrative medicine centers in the United States. The center has a patient-centered East-West model. We emphasize, wellness prevention, disease prevention, treatment, and recovery. And all of our physicians are either MD or DO trained, and we do our best to integrate the best of conventional biomedicine with an evidence-informed integrative approach to health. But what makes us truly unique is that each of our physicians or MD DOs are specifically trained with the traditional Chinese medicine philosophies and modalities. So that allows us to truly bridge kind of Eastern and Western healing traditions. And so our center has grown, right? So it's now 22 MD/DO physicians. We also work very closely in our clinics with our acupuncturists. So we have 10 now. Recently just hired another one. And we also have 8 additional education and research faculty. And we have, now 6 outpatient programs, and this is outdated, 2 inpatient hospital programs. So we've gone from Santa Monica Hospital, which is a smaller community hospital, and this month we launched at Ronald Reagan Hospital, which is the main UCLA hospital. It's a quaternary care hospital. So through Dr. Huey's leadership, the center has really grown, right? It has deep roots internationally. So Dr. Huey and one of our research faculty, Weijin Zhang, Dr. Zhang, they have collaborated with programs in Poland, Germany, Brazil, Taiwan, Hong Kong, and of course, China, truly building a global network. And we have a really robust international exchange scholars program. We also have regional partnerships. So closer to home, the center has built a strong regional network with community and nonprofit organizations. So these include, we have an acupuncture network. We work very closely and within safety net community clinics. And this year, we've also expanded to youth centers and schools as well. I'll talk a little bit more about that later. And then within UCLA, our projects span research, education, community engagement, social media presence. But the strongest pillars for us remain clinical care and education. I've been told by Dr. Huey, you need to be realistic. We can't be good at everything. So, I guess our strong areas of focus are really clinical care and education. So I'll talk more about that too. So when I started 10 years ago, there were 8 physicians and 3 fellows and 5 faculty. We now have 22 doctors spread across 6 sites, which are shown here. We have offer after hours. So after we work until almost 7. We have weekends and we have group visits, all to improve access. And despite significant growth in our physician base, we still can't really keep up, and we still have really long wait times. And so when Peter mentioned earlier, what's the longevity? I think the longevity is really the patient's demand, right? The patients and people are requiring our services. And so that's why our department has really allowed us to grow. In addition to the physicians, we also have subject matters that help us with our community engagement, education, and research efforts. Missing on this, which I realized today as I was reviewing the slides again, is our 10 acupuncturists, right, who also play a significant role. They're integral in not only helping with patient care and providing acupuncture and healing the patients, but they also teach our fellows, they teach our educational trainees, including medical students, resident physicians, and so they are also a part of our clinical and education initiatives. And I have already asked our administrator to change this slide. So for patient population, the center has continued to grow in the last 32 years, right? We did have a hiccup during the pandemic, but we recovered pretty quickly. And last year, our numbers were higher than ever. Most of our patients are referred by the 500 plus specialists within UCLA, specialists and primary care doctors within UCLA. However, we get referrals from all over Southern California. I mean, we have patients from Palm Springs and Santa Barbara, sometimes even further north. And because I think we are the only integrative program housed within an academic institution in LA, right? So I know City of Hope now has integrative oncology, and USC has inpatient integrative pediatrics, but on the inpatient side. But that's really it to my knowledge. So for general conditions, we are kind of where people go to be seen. UCSD has a very robust program, but for LA, we're really the main place. And we also get word of mouth referrals from family and friends, and we have a handful of patients who find us themselves online. And last fiscal year, which in the academic world is June to July. So, June of 2024 to July of 2025 fiscal year, we saw over 44,000 patient visits. So it's one of the, biggest programs. And then in terms of who comes to find us, who do we see? It's patients who have, who prefer a more natural or holistic approach. They prefer not to use pharmaceuticals as first-line treatments for their chronic illness. We also get patients with refractory symptoms despite, conventional medications and surgery, those who have exhausted conventional care and it didn't work. And so they need to try something different. We also see a lot of patients, like special population patients. So patients with cancer or infertility or autoimmune conditions or chronic pain patients where they really need adjunctive symptomatic relief and to help them get a more successful outcome. And then finally, we have patients who are actually pretty healthy, right? They're healthy, they're well, they're here to just learn more about how to stay healthy and stay well. And so that kind of summarizes our patient population. And then our model is that we have a very long visit, right? The first visit is an hour long, and the intake is both from an Eastern and Western medicine perspective. So we'll ask the usual conventional Western HPI questions. Then we also ask an integrative self-care assessment, right? Talk about behaviors, so health behaviors, sleep, diet, stress, exercise, what kind of work they do, what kind of trauma history they might have. And then we also add an Eastern assessment. So we'll look at their tongue. We may or may not feel their pulse. We ask also seemingly random questions, but actually help us in the Eastern pattern front. So we ask them like, are they hot, cold? Do they have palpitations, reflux, bowel movements, menstrual cycles? You know, all these additional symptoms help to formulate more of an Eastern pattern. And so with the pattern and with the Western diagnosis, then we decide what kind of treatment might be helpful. So acupuncture, cupping, you know, sometimes we prescribe medicine if it's needed, right? When symptoms are really severe, it does warrant medication. We'll prescribe for them, or supplements and botanicals. And then we also spend a lot of time doing education on self-care. So that's nutrition, typically, you know, TCM food therapy to help their system rebalance. Talk a lot about stretching, sleep, stress management techniques, posture, ergonomics, movement, exercise. There's a lot of things that we'll counsel on depending on the patient. And then we also help them put together an integrative team, really to round out the specialists, right? We don't think we know everything, and the patients definitely need either skill building or more formal evaluation. We might recommend, you know, an acupuncturist or a nutritionist or an integrative rheumatologist, physical therapist, chiropractor, massage therapy, you know, psychotherapy. Those are all just examples of, you know, how we can round out this integrative team. But ultimately, our approach is about tailoring each treatment to the individual, right? We meet the patients where they are. We consider what are they open to, what's financially feasible, and then help them figure out what makes the best sense for their health and for their circumstances. And so I'll go into a little bit more about the operations piece for the clinic. So these are our clinical programs. We have 3 ambulatory or outpatient clinics. So we have Santa Monica, Westlake Village, and Torrance. We also have 2 inpatient hospitals. So there's a community hospital in Santa Monica that's been there for 7 years now. And then this month, again, we went into the main UCLA hospital in Ronald Reagan. And then we also have an extensivist clinic. So this clinic is specifically for the sickest and highest utilizers of the UCLA healthcare system. So for patients that are going in and out of the hospital, in and out of the ER, the goal of this program is to really reduce that. And so our patients are seen much more frequently at this extensivist clinic. And then finally, last year, we formalized the collaboration with the Safety Net Community Clinic, or you know, what we call FQHC. And here at this clinic, we primarily see under-resourced patients, which is in downtown LA and in the San Gabriel Valley. So these are our sites. In terms of how how the clinic operates, we use insurance, right? A lot of patients find us because we are insurance-based. And because of that, there's also a lot of pre-visit work, you know, on the part of our staff to help coordinate, make sure insurance coverage is verified, especially since we see so many different types of insurance. And I'll talk a little bit more about that in a second. And so the patient is seen in our model of care, the patient is seen by the physician every single visit. So there's an E&M service, which is what the physician bills. And the physicians may see our own patients. So I might do a new patient consult. I might provide the acupuncture, cupping, or trigger point treatment. And then for follow-up, they can either continue to see me or they may see one of our acupuncturists. Even when they see the acupuncturist, the physician will still step in afterwards to discuss, anything, either medication or medical related, or just for further self-care recommendation or for trigger point injections. And our attendings are also seeing patients with the fellows as well. So in a full day, we see on average about 20 to 25 patients. But the biggest thing is, there's a lot of education for patients about what we actually are. Sometimes there's a confusion, right? Are you an acupuncture clinic? Well, we're not really an acupuncture clinic. We can't see patients the same as a patient might see an acupuncturist in the community. Or they might see an acupuncturist 2 to 3 times in a week. We see patients maybe once a week, but usually every 2 weeks, sometimes once a month, right? And so it's more just about kind of coordinating their care. And we're also not functional medicine. We're not homeopathy. We're not specialists in Ayurveda. Our focus is more on the TCM aspect. So in terms of patient volume and payer mix and the financial model, so at each visit, there is an E&M service, again, because the physician is billing. There may or may not be acupuncture, so there's a separate charge for that. There's a separate charge for cupping, and then a separate charge for the trigger point or tendon sheaths. Again, patients don't get all of these all at once. It's kind of pick and choose, whatever their insurance covers or whatever the patient's comfortable with. For the reimbursement and collections, it's through insurance, right? We get paid by the insurance, or if the insurance doesn't cover, we do a much reduced cash rate. For example, for insurance, UCLA, by the way, we had nothing to do with this, but UCLA billing decided we're going to charge $211 because that's kind of the going rate in the community for an acupuncture service. So they will charge the insurance $211. We definitely don't get paid $211, but we get what we get. And then for patients where acupuncture is not part of coverage, I think it's $66, right? So like much lower, because, we also have to take into consideration sometimes for the doctor's visit, there's a copay. And so we try to keep our cash rate for acupuncture as low as possible. When I started, I think it was 40 10 years ago, and now it's 66. So we haven't really raised it that much. And then for what is the cost to the clinic, for our staff physicians and our acupuncturists, they're paid hourly. Our fellows are on a fixed PGY salary. Our faculty physicians are supported by the Department of Medicine, and we are all on a tiered incentive program. So unfortunately, it is RVU based. And then for those who are in either do a lot of research or education or administrative roles, there are benchmark or RVU corrections. So the benchmarks are lowered so that you don't get penalized for doing other non-clinical activities. And then some of us are bought out by philanthropy as well. So if we have a program that we're working with a donor to fulfill, sometimes some of our time is supported by donations and philanthropy money as well. I forgot this other slide. So these are the codes. These are the CPT codes, so for office consultation, for new patient visits, for return visits, and then for each of these services, for acupuncture, trigger point, tendon sheath cupping, these are the codes that we're getting, and these are the work RVUs. So as I mentioned earlier, there's a lot of pre-visit work, right, in order to do this without having a mess and without having patients being upset. So before each visit, our patient service representatives or PSRs, they call and check with the insurance on what's covered. And then this is the chart or the grid that we give patients to sign at their initial visit saying, hey, we reviewed this with you. This is what's covered. This is what's not. For on this left-hand side, for example, for this patient, everything is covered except acupuncture because they are not in our network. But we do give them the phone number to call if they want to get acupuncture in the community so that they can do it at a much lower cost, right? They can do it here for a cash price with us, or they can go into the community. And we do most of the time, we're like, just go to the community. You can be seen much more frequently, closer to home. It makes more sense. And then for this patient on the right, this is Medicare, right? So Medicare only covers acupuncture in an MD office, which is, not something that makes too much sense for us. But unfortunately, that's where we're seeing a lot of patients is the Medicare patients, because it's covered in our office. And so acupuncture is covered as long as there's a diagnosis of chronic low back pain in this case. And so our patients will sign this, and then inside the patient room, they will also sign another form going through each treatment and whether they want it to go through insurance, to pay cash, or to not do it at all, right? So we do it, it's called an ABN, which is typically for Medicare patients that are for services not covered by Medicare. But, we actually do this for all the patients, for all the treatments, for all insurances, just to kind of cover our basis and make sure, again, that they're comfortable. And then on top of that, we have consent forms for the treatments itself. So those are a lot of forms. It's been frustrating this last year. A lot of this was the charts for the coverage has been with us for 10 years, but the new forms were all started within the last year. And so it's a lot of work, but it does help to reduce, messages, phone calls, and upset patients. It helps to improve patient satisfaction. And so one of the questions we often get is, what's the payer mix, right? What insurances are coming to you? And so about 59% is commercial. We have about 16% Medicare. Other is 11%, self-pay is 7%, UCLA managed care. So UCLA is within we have our own HMO, that's about 6%. And then we have 2% Medi-Cal. We do take Medi-Cal patients. Medi-Cal actually surprisingly covers acupuncture twice a month. So moving on to inpatient consult services, we now have 5 faculty, and 2 of my fellows are going to be joining this team. This inpatient consult provides services like acupuncture, trigger point injections, and non-pharmacological pain management approaches for patients who are hospitalized. Most often they're seeing patients with cancer who have chronic pain or functional disorders. And like I mentioned earlier, the Ronald Reagan just started this month, and Santa Monica Hospital has been, and we've had that service since for the last 7 years. And so typically they're being consulted for functional pain, low back pain, neck pain, headache. We're also seeing a lot of patients in the HEMONC ward for pain and anxiety related to cancer or chemotherapy related side effects like nausea, neuropathy, insomnia, fatigue, failure to thrive. Sometimes there's also surgery patients. So for post-op ileus, post-op pain, small bowel obstruction, occasionally, I think rarely, there's some pediatric referrals and some OB/GYN referrals. The ER is on here not because ER consults them, but because sometimes the hospitalists will ask our team to go see the patients in the ER before they're even admitted. I mean, because this program has been going on for so long, the doctors are very familiar with our team now, and so they may even refer them before they even get onto the floor. And so our inpatient team has been really good about doing their research and outcome studies. And so the inpatient team is also the extensivist team, by the way. So I kind of lump them all together. So the extensivist program, again, are seeing the high utilizer patients at UCLA who are in and out of the hospital, in and out of the ER. So the first study showed that there was a statistically significant decrease in the number of hospitalizations by over 30%, and decrease in hospital days by 38%, even after 6 months. So they concluded that the East-West extensivist care was able to reduce hospital frequency and reduce total hospitalization days. So those are big metrics. And then the second study looked at a 30-day readmission rate for those that encountered our inpatient team, right? So they looked at 1,200 admissions for pain, at the Santa Monica Hospital. And those that met with our inpatient team and I experienced treatments of acupuncture and or trigger point injections, there was over 85% reduction in the 30-day readmission rates. So, if you if you're in this hospital world, they really, for cost effectiveness and for hospital quality and for managing healthcare costs, these are really important data points. And okay, so moving on to education programs. So this slide highlights our education program timeline. And the impact in just our last fiscal year alone, right? So in the last year alone, we helped to teach over 300 students and medical students. We had trained over 70 residents and fellow physicians, over 100 healthcare professionals. We have 12 plus educational training programs. We did 8 workshops and conferences, and we have over 2,000 social media followers. That's actually a surprise for me. I last time I looked, we only had 300. So this is not an insignificant jump, I would say. And there's a lot of programs here listed. I can't really go over all of them, but I am going to do my best to go over some of the big ones today. So one of the very successful and very lucrative summer undergraduate course is the Med 185. And so this is an undergraduate summer course. It's been ongoing for 17 years. And it's focused on integrative health and well-being for mainly young adults, right? The student demographic for this course ranges from high school students. Most of them are undergraduates, but there are also medical students, sometimes senior citizens and patients who are just kind of really interested in it, take it for not for credit, but just to kind of audit the program so that they can learn for their own health and well-being. And this was an in-person course when I first started, but now it's, since the pandemic, it's fully virtual. And there are live weekly sessions with our faculty. And then there's also asynchronous online modules. So this model has worked out really well. So now we can actually have more people. I think this year we had 60 or 70 students. So the next education program is really our fellowship program. This is the one that I run. I'm the program director. This fellowship is for MD-DOs, physicians who've completed internal medicine, med peds, or family medicine residency. I mean, we would love to take all different specialists, but because we're trying to keep our service broad and we want to be able to see all adult patients, this is really the only way to kind of keep it very broad. And the fellowship itself is 1.5 years. When I started, it was 2 years long. We were trying to, there's always this debate. How long do you really need to learn traditional Chinese medicine? And so we've tried there are some faculty who are like, we need it to be 2 years. And then some they're like, oh, you only needed a year. So I kind of compromised and went with the 1.5 years, but our fellows are required to stay on for an additional 2 years to kind of hone their skills and to kind of continue this model. Part of that is for retention so that we can grow the program, but part of it is also because, as many of you know, it takes a long time to fully implement, digest, and really understand these concepts and the philosophy. So we have up to 3 fellows per year. Their salary supported by the department. And then the education and administrative support is fully funded by philanthropy. We are the second oldest integrative medicine fellowship in the country. We were established in 1999. I think the Arizona fellowship was the first. But what makes us very unique out of the 20 or so programs in the country is that we're the only one recognized by both the ABOIM and the ABMA, so the American Board of Medical Acupuncture. So that was something that we accomplished, I think, last year in 2024. We also got re-recognized by the Academic Consortium last year. Well, that time flies. Last year, and we were recognized for 5 years. So we're very happy, and we are one of the very few fellowships that's actually all clinical, right? So a lot of programs I think are now virtual or online, but I think we're finding that we have more applicants than ever because there are just very few fully clinical programs where everything is in person. And our fellowship is almost like an apprenticeship, right? It's like they're in person seeing patients every single day. Okay, so moving on. So this is another program. We were thinking, how can we train not just full-time fellows and we only get 2 or 3 a year? How can we expand our reach? And so this is a new program, and the pilot program just started this year. This is called the Churn Scholars Program, where we're training early to mid-career UCLA physicians. It's a 200-hour hybrid certificate course, so it's not a fellowship, but it's a certificate course with focus on integrative medicine, Chinese medicine, and acupuncture. And when they're done, they're eligible to request for privileges, which would require some additional supervised acupuncture, but additional hours of supervision. But I think they could, the time that they're using to do the program also counts. But the ultimate goal of this program is to build champions, right? Champions across different departments, different divisions. We want an integrative urologist, an oncologist, and pediatrics and addiction medicine, and the traditional residency physicians who can't actually apply to our fellowship. We want to be able to have champions everywhere. And so this year, this is our pilot cohort. We have a palliative care physician, we have a hematology oncologist, we have a pediatric GI doctor, and we have an addiction medicine physician. So the 200-hour curriculum most of it is self-paced online modules that we've been, putting together the last 5 years. But we have a 72-hour in-person clinical part where they're learning hands-on acupuncture, trigger points. There's in-person case review sessions, academic day conferences, and then we encourage them to attend, UCLA and national conferences. And then finally, I just want to mention we have an online CME course as well, CME and also CEU. This is primarily focused on chronic pain. And then we do a lot of teaching at the medical school and for the house staff, so the residents at UCLA. So I teach the family medicine, integrative medicine workshop with an acupuncture experience, which they love. They're like, stop talking, let me practice with, let's poke each other. And this happens 5 times a year. So really, I'm able to reach all of the medical students this way, right? In the past, we were only doing electives and selectives. So it's kind of a self-selecting group of students, maybe 15 or 10 here and there. But now we're able to kind of incorporate integrative model to all the medical students. We also have a 4th-year student elective that's more intensive. We have a 3-year discovery, a 3rd-year discovery track, which is a 9-month experience for med students to dive deeper into a specific field. And so ours is focused more on developing integrative medicine programs for the local Asian American community. And I think last year we were able to train, we have a lot of rotators. So med students and residents that rotate through the clinic and shadow and get hands-on training and experience. Okay, so moving on to community engagement. Last year, with the help of one of my junior faculty who's med-peds trained, the 2 of us launched the pediatric program. And while our clinical practice is still growing, we are, meaning like we're still getting more and more referrals, we really wanted to focus on how to engage the community. And so because of this, we started partnering with nonprofit organizations like CHIP, which is a creative healing for youth in pain, along with local schools and youth centers to kind of expand our reach. The ultimate goal here was really to educate the community on non-drug therapies for pediatric mental health and pain, issues that are really prevalent and problematic today. And so we developed this was a really fun project this year, but we developed a 12-week after school and during school mental health curriculum. It's like 30 to 45 minutes a week And the program includes, we put together all these videos so that it's really easy for the facilitators to implement, but videos for Qigong, introducing Chinese medicine concepts, Qigong, acupressure, mindfulness meditation, TCM nutrition, and art therapy, right? So all designed to promote emotional well-being. And as the program rolls out, we're going to evaluate feasibility, acceptability, and outcomes to strengthen and refine the model. But the goal of it is really just to, after our pilot, which will be the spring of next year, we'll give it to whoever wants it. It's a free program. We're going to, whoever wants it can have it, basically. And so I was going to show just I don't know, can you guys hear the video?
No.
No, okay. So I'll I'll explain. So this is the Qigong video for our younger elementary school students. So this is Sarah, Dr. Sarah Potasnik, and she's doing 3 movements for the water element. So the 12-week program is centered around the 5-element constitution for kids and mental health. And so for each element, we pick 3 moves and 3 Qigong moves and 2 acupressure moves. And so we made videos for each of this. And so this is part of the 12-week curriculum. Full disclosure, that's my daughter. But this is something easy that the kids can learn to implement, and it's part of the curriculum. And so, yeah, I'll stop there. And then these pictures are really from, this is a mindfulness video that we shot as well. So in addition to the curriculum, we're also putting together an annual community conference. Again, it's designed for parents, caregivers, teachers. Some healthcare professionals always come, but again, it's about, teaching the latest science on root cause of chronic pain and mental health in kids. And then we do a lot of workshops to equip the participants on how to give them practical tools that they can bring home. And then we have, finally, we also developed a website and resource page for patient care in the community. And so that includes, TCM practices. These videos will all be housed on there. We have a website for sleep strategies. There's links to free yoga programs, mindfulness apps, and curated book recommendations for parents. So these are all different ways that we're trying to engage the community. And then on the clinical side, we also engage the community by partnering with FQHCs, right? So this is a FQHC called CSE Health. We have been able to replicate our UCLA services at this under-resourced safety net clinic. We also, our faculty, go there. They are paid by our department. Their salaries are subsidized so that they work in these community clinics. And we've been able to incorporate mind-body programs, dental programs, pediatrics. Sarah works there 2 days a week, and she also teaches Qigong at their youth center. Our fellows are now going there also in order to learn how to treat different patient populations, and our med students are going there as well. And then, I think I mentioned earlier, we have a lot of conferences every year also to engage the community. And then finally, research, right? So as I mentioned earlier, we can't be strong at everything. And so the research output is definitely less robust than our education and clinical programs. We don't really have a dedicated research faculty. And because of such high patient demand, we that has to be the priority. That's what the department wants. And so we do, every year we're required to put out case reports. Some of our faculty have put out book chapters for integrative, approach to sinusitis or allergy. There was an eye health chapter as well, I think recently. We've done some smaller randomized control trials, like we did one on Tai Chi and headache, perineal acupressure for constipation. Dr. Andrew Schubach did one of the first Chinese medicine herb I can't remember the name of it now, but he did, he presented this at the academic consortium, but it was about a patent Chinese herbal formula for the treatment of COVID-19. And we did an acupressure for stress management for healthcare providers study, I think, during the pandemic as well. So there's, here and there we'll have projects, but it's just not as robust as we'd like. So in order to do it, now that we're growing, and now that we have more faculty, we have more interest, we are starting to build the research infrastructure. So that includes, so Wei-Jin is starting an international exchange platform for Medicare students interested in integrative medicine. So he's putting together 11 universities that offers medical education and integrative medicine in East Asian countries to kind of get a research network. The UCLA actually was awarded an NCCIH REACH grant this year. It was a $3 million grant that included 6 local acupuncture schools and art therapy programs. And the grant was really to enhance workforce development, right? And to help with interprofessional training and how to help everybody succeed. But obviously that all is on hold right now. And then we also have joined research networks. So we've joined BraveNet. I'm sure many of you guys are already familiar with that. And then we also joined Imagine. So that is a research network of integrative oncology care centers led by Memorial Sloan Kettering, looking at massage and acupuncture for pain management. So this is something we're still working on. So in the interest of time, I'm going to pause there. Does anyone have questions about this piece before I kind of show a case of how we would potentially treat? Any questions about our research, education, or clinic operations?
There were
some questions in the chat.
Yeah, I can read them out. Some of them I think you have answered. So if you feel like you've already covered it, no worries, but I'll just read it out anyway. So Justine Green had a few questions. Are all of the evaluations and services performed by physicians, or do you have support staff? And do you have specific protocols to decide which patients need which services?
Let me see. Where was that question? Beginning?
Oh, there's a Q&A section on the bottom.
Oh, maybe, sorry, I was looking at the chat. So the question was really, is there a protocol for who gets what treatment, and is there, I see. There's not really a formal protocol. I think if the patient is interested in acupuncture or trigger points, and if it's indicated, right? If they have a condition for which there's evidence to support that it would benefit, we give it a try. In terms of who sees the physician versus who sees the acupuncturist, I think for most of our MDs that have been here for a while, our schedules are and our return visits are so far and few in between that most of our patients will go to the acupuncturist and we follow along, right? So they're the experts. They dictate the treatment protocol. We're just following along and then add value in the conventional medicine, or if they need trigger point injections, which in California only MDs can do.
Thank you. There are some questions about the fellowship. Olivia Dhaliwal asks, how many of your fellows came from out of state? How competitive is the fellowship? What alternatives, additional programs do you recommend if a current resident is really interested in further education in TCM? She's seeking higher education in acupuncture with the local school of TCM, Jung Tao in North Carolina, and she did the Helms Medical Acupuncture training this past year.
Yeah. I mean, the fellowship is, I would say, moderate. Well, we take equal number of in-state and out-of-state. I don't think where you are located necessarily, we don't have a priority of in-state or out-of-state. It's more, do you have a plan to practice in California in the future, right? The goal, because the department is paying for the salary and their goal is to grow the program, to improve the access to the care, the patients, they really want to, prioritize people who might stay, right? I mean, who have family nearby or have who have plans to stay, basically. With that said, we do take, we try to take just good candidates in general. I don't know if that answers the question. And then for additional training in TCM, I mean, it sounds like Olivia already is pursuing the extra training. I mean, some of our physicians didn't do our fellowship. This is a long time ago, and they did Masters of Oriental Medicine at local acupuncture schools. And I mean, completing the Helms course, you're eligible to take the medical acupuncture boards. And so in theory, you should be able to practice anywhere in the country, right? So I think you're doing all the right things.
Awesome. Thank you. And I think the only other question I saw was asking about the slides, if this audience would be able to have access to them.
Sure.
And that was it.
Okay. All right. So
I'd
I
like
will.
if I could throw in a question here.
Yeah.
So in the TCM piece, you've spoken quite a bit about acupuncture, but I wonder if you're also doing Chinese herbal medicine as part of, your TCM.
It's part of the didactics, but in practice, because we're operating within the academic institution, in the past, it was asked that we limit. That's the reality, and that's the truth. It was asked that we limit herbal medicine. With that said, we do. We usually, it's more of because we're not customizing herbal recommendations. It may be just patent formulas, like common formulas, right, that we think might help the patient. I do, and I know like half of our faculty do. Some shy away from it just because it's not necessarily encouraged from the health system standpoint, but we do. The fellows, I don't feel are fully adequately trained. And so a lot of it is, if you are interested in it, the ones that are interested dive deeper on their own. But it is part of their weekly. So part of our fellowship curriculum includes weekly 4-hour didactics with a TCM professor. She's a professor at the school, local acupuncture school. She has her own practice, and then she's been teaching MDs TCM for a long time. And so she goes through most of the traditional Chinese medicine foundational concepts and points, and she goes through herbs as well, but it's not as deep.
You said you have some people though who have taken a masters of traditional Oriental medicine. So that training would have completely oriented them.
And those faculty prescribe herbs and sometimes will customize, and but even I don't think, because I don't think we're allowed to because with the custom herbs, you have to they have to pay you, and so there's no way for us to receive payment and order for them and things like that. And so usually it's still patent formulas that they get on Amazon or buy on their own online.
Thank you.
Okay, so I'll end with a quick case. This is a case that I go over with our med students every couple months. It's something that all of us deal with, is chronic neck pain. So this is a 38-year-old female. She has a past medical history of allergies, anxiety, chronic pain for 4 months. There's no clear inciting event. There's pain from 3 to 8 out of 10, dull, achy, bilateral. Sometimes it's sharp with movements. It's focused mainly along the base of the skull, sometimes radiates to the trapezius, sometimes radiates down the back of the shoulder. Pain is worse with long hours, stress, poor sleep, improved with NSAIDs, so Aleve, Advil, and massage, but the benefits are temporary, right? And so on the left side here, these are our common, Western history. So review of systems, she's got some occasional headaches, ringing of the ears, had a history of motor vehicle accident at age 10. Family history-wise, she's a mother with anxiety, diabetes, hypertension, father with a history of alcoholism, stroke. Again, like I said, as needed, muscle relaxants or anti-inflammatories, known allergies. She's a NICU nurse. She's married with 2 young children, lives at home with husband and kids, no tobacco, drug use, and occasionally drinks over the weekend. So on the right side, this is more of what we call the integrative assessment. And so it's really lifestyle and behavior. So she sleeps about 5 to 6 hours per night. It's interrupted. She has difficulty with initiation and staying asleep. No regular exercise, 2 to 3 cups of coffee, skips breakfast, some processed breakfast, grab and go lunch, dinners, kind of carry out, or homemade protein, vegetable, and some carbs, some fried food, some processed snacks. She tends to be constipated. She's a mother with, so we always do an ACE assessment too. So there's a trauma history, right? So adverse childhood events. It's commonly linked to adult, chronic disease. And so we always think to ask, was there any, how was your childhood? What was that like? So in this patient, the mother has had a history of mental health and father with a history of alcoholism, which all, as we know, adds a lot of stress to childhood. And then we also make a point to specifically ask about stress, right? So emotionally, if you don't ask, sometimes people really don't divulge. And so for this patient, she had an emotionally abusive partner, kids with mental health conditions, and now she's also taking care of her parents. And so by the end of this, we can understand that the patient is sandwiched in the caregiving department. She has kids who need extra attention, a partner who's not necessarily supportive, and parents with elderly health issues. And so by the time you're done with this piece, you're kind of understand where her pain and tension may be coming from, right? So here, her labs were normal. Her imaging, she had an MRI because of the numbness and tingling down the arm, but the MRI was totally normal. And so for conventional therapy, she's already on the NSAIDs as needed, the muscle relaxers. Sometimes we'll recommend gabapentin for nerve pain. It's oftentimes physical therapy and a referral to pain management or a physiatrist for procedures. And, there is a place for these therapies, right? For patients who are really busy, very little time, or in severe debilitating pain, sometimes it makes sense for them. But then for our approach, we really focus on lifestyle, right? So there's a lot of data showing that stress for chronic neck pain, which is this patient, is the most important factor, right? So Stanford University evaluated patients who are symptomatic and asymptomatic with abnormal MRI findings, and they concluded that the severity of the MRI lesion did not predict the presence of pain. It was actually pain severity correlated more with underlying psychological issues, right? Another study showed pain is more likely to become chronic in patients who catastrophize, somaticize, or feel a lack of control in decision-making. And then a big study in a British study with 12,000 patients concluded again that perceived neck pain and mental stress was a stronger associated than neck pain and repetitive occupational activity. So we often think it's posture, ergonomics, or heavy lifting, but it's actually neck and mental health. So For stress, again, you meet the patients where they are. There's a lot of different ways to help reduce the stress that are evidence-based. So CBT, meditation, yoga, Tai Chi, deep breathing, journaling, movement and exercise. So there's all different ways to address this stress. You just have to figure out what makes the most sense for this patient. Other lifestyle interventions. So there was a neuropsychoimmunologist at UCLA who studied sleep and its impact on inflammation on the system. And what he found was that it's not the duration of the sleep, but how interrupted the sleep is. The more it's interrupted, there's more systemic inflammation in the body. And so with pain, or specifically myofascial pain, especially if it's an active trigger point, there's not just the knot itself, but the inflammation that surrounds that area. And so we do need to address underlying inflammation as a root cause for this pain too. So for sleep, we often recommend things like magnesium, lemon balm. For certain patients, it may be sleep hygiene or CBT, cognitive behavioral therapy for insomnia. And there's, literature now on the breathing exercise, the 4-7-8 breathing exercise to help with getting back to sleep, right? So for patients that are waking up in the middle of the night, having them try the breathing exercise instead of going to their phone. Any regular physical exercise has been shown to improve chronic neck pain. Tai Chi and yoga specifically has really robust data, but really any aerobic exercise. And we often counsel on avoiding heavy lifting. And from the dietary standpoint, it's, avoiding inflammatory foods. And I'll talk more about that in the next slide, and also increasing hydration. I can't tell you how often I see a patient and they're like, I drink 2 cups of coffee, I have 2 drinks of alcohol, I exercise a lot, and then I'm in so much pain, right? But all of that is super dehydrating. And if you're not getting enough water in, how I tell the patient is you're not getting enough lubrication, your muscles are cramping and tightening up, and so you're going to be in more pain. Right? So these are kind of very basic things that we talk about all the time. And then in terms of foods that specifically increase inflammation, I think most of that has come from the cancer research, because at the root of cancer is also inflammation. And so these are the foods that have been studied that might increase your risk of cancer. And so avoiding too much consumption of red meat, processed foods, there's the semi-processed and the ultra-processed, but ultimately, trying to eat more real food in general would be helpful to reduce the inflammation. More than 7 drinks a week has been shown to increase breast cancer, and alcohol itself is tied to at least 6 to 7 different types of cancer, right? Because of the inflammation process, and any kind of refined or processed sugar. So these are the 4 groups that we really counsel on reducing to help reduce pain. And then patients are like, what do I eat? Well, real food, that's it. Like, we can talk more about specifics from a TCM standpoint, but generally speaking, this is the first step, right? Is to cut out the bad stuff. And then, for chronic neck pain, acupuncture is indicated, and it's evidence-based. It's actually evidence-based for many chronic pain conditions. So these are the ones listed. As I mentioned, for low back pain, there's such a wealth of data now that even Medicare covers it, but it's very safe. This is what I share with everyone. It's extremely safe. And then, you can also, for chronic neck pain, do trigger point therapy, assuming it's myofascial pain or there's myofascial trigger points. Trigger point therapy is a simple, quick procedure that can be done in urgent care settings, primary care offices, at our clinic. The goal is just to really deactivate the knots, and patients can walk out feeling much better. And this is pretty similar to the acupuncturists and their form of dry needling, right? So it's really just kind of deactivating the knots. And there's a good amount of data. Acupuncture and trigger points there's over 95% overlap. So it's really Eastern and Western medicine coming together. And then other evidence-based manual modalities, so massage, chiropractor, osteopathy, cupping. We also recommend topical therapy. So there may be less evidence for topical therapies, but it's certainly more safe, right? It's not as systemic, there's lower risk. So we'll recommend things like heating pads and topical oils. One of my favorite is a Posum oil. There's patches. One of my favorite is Salonpas patches, especially for people who are sedentary or very exertional. It's great for airplanes and when you're at work, if you're moving around a lot. Lidocaine patches, CBD oil, topical magnesium, those are all things that we commonly recommend and could be recommended for even our patient with the chronic neck pain. And then self-care tools, right? So again, behavior, our daily behavior contributes much more than actually even healthcare in our overall health, right? And so we all have bad posture. We all have tech neck. We have, a lot of reasons in our modern society to have tight neck and shoulders. And so we often recommend tools that can help to release or reduce the tension on a daily basis. So that could be a TENS unit, that could be a massage gun, that could be, a YouTube video that's 10 minutes of stretching, or 10 minutes of qigong, which are, but they're simple, they're short, they're free. Some of our patients can't make it to physical therapy because they're too busy. And so these are just, again, resources for patients to do something on their own at home every day. There's also posture correctors, making sure that their ergonomics are correct. There's acupressure mats, shiatsu neck massagers, tennis balls. Tennis balls is Dr. Huey's favorite thing to recommend because it costs very, very little. So you put 2 tennis balls inside a long sock, and it can help to massage different acupressure points, right? And that's the same concept for a therapy. And then finally, for herbs or supplements, we'll oftentimes recommend magnesium, not just because it helps sleep, but also because it's a natural muscle relaxer. And turmeric, sometimes if there's arthritis also contributing for the inflammation component, turmeric may be something we recommend as well. And so, in summary, this is just an example of, where for us, chronic pain, there's almost always some underlying emotional or mental health component. If you ignore this piece and just do the treatments, the pain is always going to come back. And so for us, it's about helping the patient get to the root of it. Is it stress? Is it your sleep? Is it trauma from the past? And we assess all the things and then address everything together. So it's like a whole person approach. Yeah, that's it. So that's the end of my talk. Does anyone have any questions about the case or about anything else that came up?
Anything else, Serena, that you see?
I don't see anything else here.
Okay.
In terms of someone said tell your daughter she did a great job. That's um yeah, so I don't see any. Oh, one question has come. How can I find a TCM practitioner?
Go.
I think there's many ways, right? I think you can, if you're looking for somebody in network, you can, a lot of insurances that, especially ones that offer TCM or acupuncture coverage, they have a network. And so you can look through your insurance, you can ask your primary care provider, you can ask friends and family, you can Yelp, right? Maybe Peter can give some additional advice.
State acupuncture societies
Yes.
are one of the best ways to find qualified people, for sure. There are literally thousands and thousands of acupuncturists all around the country, so
Right.
you won't have any trouble finding one. Find one that you like. I do think the state professional society route is one of the best to go through. And, word of mouth, of course.
Yes.
There's a question in the Q&A that I actually was curious about as well. Are your medical education programs or rotations accessible to visiting med students from out of state?
At this time, no. mainly because we have so many requests internally from our medical students, from our multiple residency programs. UCLA also has affiliated programs. So for example, Harbor UCLA or All of You Hospital. And so these affiliated programs are also asking. So at this time, it's pretty, I believe it's pretty hard. And it's not just visiting, right? It's also our schools have to, there's some process with the schools where if you are a medical student, your liability insurance and all that has to like come together with UCLA. So it's actually a much bigger process. And so most of the time it doesn't work out, unfortunately. But we do, I think out-of-state students often do our undergraduate course, right? Like our, the Med 185.
Sorry,
But
just
there's
to add
also, just to be clear, there's integrative programs all over the country, right? So if you're interested in shadowing an integrative practitioner, there's OSHA centers, there are integrative programs like all over the country that are really great. And so maybe you find one maybe within your state, it might be easier to coordinate.
And yeah, just to answer from like my perspective being at
Oh
Kate.
yeah, I forgot. Sorry, Serene.
No, it's because I was able to get and I'm a fourth year, so I was able to get an unlisted elective in integrative medicine with university hospitals. And CCF Cleveland Clinic also has an integrative medicine elective for third and fourth years, I believe. Um, so at least that's available. Doctor Who, just gonna add residents on there. I know you mentioned a lot of residencies are also wanting to rotate with you. Um, are you guys open to residents like out in the LA area, or is it really just mostly in the UCLA network?
I think if you're a resident in the LA area, again, there's an issue of the liability and the affiliation. If we can get that to work with the GME office, so it's not even within our office, it's within the UCLA General Medical Education Office. If it can align, we're open to it. Especially we want fellows, or like we want residents who, if they're interested in our fellowship, to actually have experience there, right? It's a big commitment. It's not just, our fellowship isn't just a fellowship interview, it's a job interview because you have to stay after for a couple of years. And so we want to make sure it's the right fit. And so to make sure it's the right fit, we'll go out of our way, especially if a resident is interested in the fellowship.
And we had another question that came up on behalf of Susan asking the question, but also everyone else. Would they be able to email you with any follow-up questions after this PowerPoint?
Sure, of course. You can share that with them. I may or may not be able to answer, but I'm happy to try. We actually met with City of Hope. Their director came a few weeks ago. Same thing. He's mostly questions about operations, and most of this slide was designed for them because they're trying to expand their acupuncture and coverage for patients.
Awesome, thank you. I think that's it for questions that I can see. So yeah, I'll try to get the slides from you so that we can share them as well as your email.
Right. You know, what's going to happen is eventually this is going to be up on YouTube, on the AIHM's YouTube channel. And I'm going to send a note to everybody who's registered for this event that, you know, it's available. And also there'll be a convenient text link directly to your talk. And so in that message that I send notifying people that the recording is ready, we could do a PDF of we could include the PDF of your slides.
Sure.
That would be great. Thank you. Yeah. So if nobody has any other questions or comments or whatever, I'm going to just say thank you so much for doing this. It's a great presentation. And that's why people want to see your slides and hear the recording. Very thorough, really covered so many bases, and is worth listening to and looking at again to grasp the breadth of the program, really.
Yeah.
So
Thank you so much for the opportunity.
oh, thank you. And Serena, thank you for being at the helm tonight again and for organizing this with Dr. Hu to begin with. I'm going to just quick mention, I'm not able to put this in to the chat or anything right now, but if anybody hasn't heard, after numerous communications about this, but the AIHM's own annual conference is coming up in actually just about a week and a half. I think it's the 24th to the 27th in Philadelphia. If you get our emails, our newsletters, you'll see links to the program there so you can check it out. They're always great conferences, and this year it's going to be in Philadelphia instead of San Diego, so more convenient for people on our half of the country. And on top of that, there's also a substantial discount for members of our chapter, or actually AIHM members in general. Anybody who's in our network and gets our messages is able to avail themselves of the discount. So just mentioning that one more time. And I think that's it.
Awesome. Thank you,
Oh.
Dr. Hu. That was, yeah,
Thank you.
I'm very jealous of everyone in the UCLA network. I think that's like such an awesome educational program.
Well, come join us, right? Come join us. That's the goal. I'm trying to
Yeah.
recruit you.
Well, if I was going to say, if I ever decide to move to California, I would
Yes.
definitely want to avail myself of your network and see if you have a job for me.
Yeah. I think you're overqualified, but yeah.
Oh, okay.
You can join the acupuncture network for sure. We always need, I mean, most of our patients are supplementing in the community. We definitely cannot see enough here. And so we always, welcome more to join the network, depending on where you live or where your practice would be.
Right.
Okay.
Okay, well, thanks again so
You're
much.
welcome. Nice
Thank
to
you,
meet
everybody.
you. Bye-bye.
Good to meet you. Good night.
Everyone, good night.